So, hello everybody. I am Amanda Newhouse, and I am clinical social work faculty here at WVU Medicine. And today I'm going to talk to you a little bit about a practical view at child versus adolescent treatment and therapy. I have done family and children therapy for close to 20 years now. And so I've worked primarily with adolescents, and I've worked primarily with children. I've worked with families, and my focus now is working with children 5 and under. And through the years, I've come to learn that there's just a little bit of practical magic with understanding the difference between children and adolescents and treatment. So I'm going to go over a little bit of that. Maybe. Oh, there we go. So the CDC recently has come out that 1 in 6 children aged 2 to 8 years old have mental, behavioral, and developmental disorders. And with the increasing rate of disorders that are coming early on, clearly our children are being faced with adverse childhood experiences that are contributing to these disorders. And with a lot of the epidemics that are coming about, the epidemic, the pan-epidemic, things that are coming about within society, it's really having an influence on our children. And so children who are exposed to toxic stress are developing this early on. And so those of you who have heard me speak before, I'm sure you've heard me get on my soapbox about the developing brain in children. And it's really important to understand that children's brains within the first 3 years are completely under construction. And so they are born with all the neurons they ever need, but those synapses that fire and wire together come about when they have some of that positive interaction. So it's able to regulate through their caregivers and their parents. And that's what structures the brain and the brain development. Now, the nice thing is that there's tons of neuroplasticity. So you can always build these pieces, but that early on interaction is really significant. And the amount of toxic stress that children are exposed to is important too. And so children need positive stress, but they also need these positive interactions. They need positive relationships, communication, they need stimulation. And so they need all of these pieces to build. When they're faced with toxic stress, we all go into the fight, flight, or freeze mode, right? So like we've said before, if you're faced with the bear, what are you going to do? Fight, flight, or freeze? And those of you who've heard me say that before have heard me say that I'm definitely freezing. Although I do have to say that that's a benefit for me in my clinical world, because when I have a parent that is angry at me and screaming and it stresses me out, I freeze and think about what I need to say to them instead of fighting back, right? So that's definitely a benefit. But if you think about how children respond, that's linked to their fear conditioning. And so some of the kids that are being exposed to toxic stress all the time, their fear conditioning is becoming completely dysregulated. So exposure to toxic stress does cause a lot of stress reactivity, and the failure to extinguish that is just a constant unknown, right? And it's just a dysregulation amongst the brain activity and their emotions. This dysregulation in children can cause aggression and mood disturbances on top of the ability to regulate. And for teens, you're looking at the constant exposure to toxic stress, dysregulating them consistently can impact the serotonin reuptake that leads to depression, suicide, and can lead to aggression as well. The other piece that toxic stress really impacts is the limbic, hypothalamus, pituitary, adrenaline axes, right? Whew, that's a mouthful. So I like to say the HPA because I don't always get to say it that clean. So I just usually say the HPA, which controls reactions to stress, regulation, and even the immune system. So this area of the brain and the development really shows the whole health, right? So how important it is to be physically healthy and mentally healthy, and how in tune they are with one another. So for children, this area is impacted by toxic stress. It can create extreme emotions, hyperactivity, and shift in emotions. And if you think about some of your patients, I think about my patients with sensory disorders. I think about my patients with high anxiety. I think about my kids with who are in foster care, who have been exposed to extreme trauma. A lot of the times I get parent reports that they have just these extreme emotions, right? They're really happy or really sad. Like when they're sad, they're really upset. Or, you know, when they're excited, they're like overexcited, overstimulated. They just can't handle it. Or, you know, when they're really mad, they're angry, like there's no getting through to them. They really flip their lid, right? And so these extreme emotions definitely are impacted by these kids because they've been impacted by some toxic stress. I have some moms with super high anxiety, really over involved with their children and creating some of that anxiety within their children. And so that's a level of toxic stress within itself too. And so that can create dysregulation. Shift in emotions is another big one. I get a parent report all the time that the kids are bipolar. And, you know, again, I mean, this is primarily 5 and under, so they're not quite bipolar. They still got some development to go. While, you know, a lot of the kids in foster care, sometimes parents will say, you know, I know their parents were bipolar. While they might have a genetic disposition, you know, the shift in emotions could be the exposure to toxic stress. So helping them understand how to counteract some of that. For teens, constant exposure to toxic stress in this area of the brain can lead to more psychiatric symptoms, right? And we've talked about, Dr. Swagger talked a couple weeks ago about some of the long-term effects, some of the short-term effects, and then some of the longer-term effects. And that's what you're looking at when children are exposed early on to constant stress, you know, some early mental health, and then if it continues and it persists, it's leading to psychiatric symptoms within teenagers as well. But this area also impacts sleep issues with teens, memory and loss, and difficulty concentrating. So what we want to do is we want to build resiliency in children. We talk about this exposure to stress, to toxic stress. Kids need stress in their lives. They need some positive stress. They need tolerable stress, ways that we can comfort them, that they can recover from it. That builds resiliency. Other things that build resiliency are also basic needs, meeting those basic needs, communication, relationships, social emotional development, and that stimulation. So a lot of this is what helps build some of that brain activity. So you can see where those are linked. And so that firm foundation also helps to overcome some of the barriers that they may come across. So how do we do this? How do we build resiliency in kids? Well, this is the magical part, right? We go back to some of the main pieces. So if we look at Maslow's hierarchy of needs, this is like some practical magic, right? It makes complete sense. But when I talk to parents about it, it's like magical. They like completely get it. But if you look at it, you know, we can build resiliency in kids by meeting these needs. And so the physiological piece, right? Having that bed, having consistent meals, and just thinking in your mind right now of how many of our patients don't get that. How many of our patients have that off and on? It's not consistent. And so you can see where there's some building blocks already taken away or not really in their pyramid. So that reduces their safety and security. You can see where, you know, different caregivers, multiple homes, feeling that they're never right, that can impact their love and belonging, which impacts their self-esteem, and all the way up to our teenagers who are building that morality and self-actualization. Like, so you can see where some of our patients have these pieces of their pyramid, you know, blocks not built or cracks within the foundation are going to have a huge impact on them. This can leave children more prone to dysregulation, some behavior concerns, developmental delays, especially early on. That's trajectory. You know, we look at that as a trajectory, one of the trajectory pieces for infant mental health and impacts of stress levels within infants and young children. And so developmental delays are one of our key pieces. If we see that, then we can explore a little bit further. Increases in irritability and impulse control concerns. So early mental health symptoms become later presentations of, this intensity within adolescence. That's when we see a lot of budding different types of psychiatric disorders. If they continue and they're persistent throughout childhood, so we're looking at the child, we're looking at school-age children and teens. If it consists through, it definitely becomes some more complex issues as it's shifting from behavioral to psychological. So these impacts on children early on, they usually have more of a behavioral outlet, so a behavioral external release of that, and they're not internalizing as much. But as they shift to teenagers, it becomes more of internal symptoms. So then it leaves adolescents more prone to depression. We know that adolescents that are risk-taking and thrill-seeking, a lot of different challenges coming about, internet media challenges that are just very risk-taking for adolescents, not really thinking about it, some impulse control issues. And it's because if you look at the adolescents, this is a little bit of an exaggerated picture of our adolescents, but if you look at adolescents' brains, their emotions are huge. The biggest areas are emotion, they're thinking about sex and sleep, right? And so if you think about adolescents, that's kind of them wrapped up in one. So definitely an emotional piece to them. And when you add trauma and substance use disorder in adolescence, that just triggers that emotional piece even more. And there's a lot of research on the brain development and how it actually can delay some of that and increase the impulse control issues. So delaying some of that logical thinking area growth and increase some of the impulse control. So a lot of adolescents who have been exposed to trauma or substance use disorder definitely have an increased avoidance, high anxiety, mood disorders, a lot of somatic symptoms, negative perception of self. So you can see where some of those blocks of their pyramid is just not there. Interpersonal difficulties and self-harming behaviors. Building resiliency in adolescents, that looks a little bit different than building resiliency in our children. Not that adolescents don't need some of those other pieces, like basic needs such as, communication, relationships. They still need those pieces, but they need more help with their decision making. So in treatment, we're helping them more with some of that decision making. And the more that we can do that over and over again, the more helpful it is, because remember, that emotional part of their brain is still very much bigger. Positive role models. So again, I see mostly 5 and under, but I do have a handful of teenagers. And because I have a smaller group of adolescents that I work with, I'm able to do this a little bit more, but I know with adolescents in treatment, I'm always trying to find volunteer opportunities for them, because having that positive role model is really important. The other piece too is it makes them feel like that sense of accomplishment. They have that sense of accomplishment that leads to that self-actualization, better self-esteem. And so that's really important. A lot of adolescents I work with end up volunteering. They're all about animals for some reason. So a lot of them end up volunteering in animal shelters, but I have some that have started volunteering in the hospital and love it. I have some who have volunteered at child care centers of friends that they know, and it's been really helpful. So this really exposes them to other positive role models, and it helps them feel like they've accomplished something. Also building resiliency in adolescents, looking for specialists that can focus on them. So specialists that have training in working with adolescents, have training in substance use disorder, if that's where the area of concern is, in trauma. And so that's really important as well. And helping them cope with, teaching them how to manage their emotions, right? So coping and strategizing around managing their emotions, how to manage them appropriately, giving them some tools and skills that they can help with. So this is the magical part, right? This is where I take all of the students back. If a student comes to me and they're presenting this tough case, they're really struggling with it, and they're talking through it, I'm like, so, if you look at some of the basic pieces of development, it is so helpful to reframe treatment at times. So what we talk about is, okay, so where are they at in Eric's Erik Erikson's 8 stages of development, right? And usually I get, I'm not really sure. So I'm like, well, let's look at it. It's important to look at it to identify where the patient is for a couple different reasons. Like I said, this is like practical magic. So Erik Erikson, Piaget, Vygotsky, like they're magicians, right? They had something going for them early on. They identified development, how it impacts individuals. And if we look at this when we're assessing individuals and we're going to treat them, it can really help with that. So the students, we always look at this. So if you have, a lot of the times we'll have a teenager who should be up here in the identity versus role confusion, right? But they're really, really insecure. They get tons of guilt. They never really are assertive about anything. We're looking at more like some initiative versus guilt issues. And so we meet them where they're at. It's really important to meet patients where they're at and bring them along. So we talk about that. So they're falling more or less in initiative versus guilt. How are we going to bring them up to identity versus role confusion? This is a great discussion to have upon intake and also with the family, because it helps the family identify how to interact. It helps you as a clinician identify how to interact and how to get your message across. When you're getting frustrated, you just can't, you can't help them, you can't progress, you can't move forward in treatment. This is really helpful to stop and take a look at. If you have a 12-year-old, so let's shift over to Piaget stages, right? So if you have a 12-year-old who is chronologically 12, but they're truly functioning at a 5-year-old level, you're not going to gain logic from them, right? You're not going to be able to talk with them about their thought process, how to stop it, where's it going. You're not going to be able to identify what that thought process is because they're not thinking logically. If they're developmentally in a pre-operational stage, then you've got to meet them where they're at. You've got to look at changing your language. You've got to look at utilizing metaphors. I actually just had this discussion this morning. You have to look at utilizing metaphors, reading books, using pictures. So they're going to get it more that way. But at 12 years old, we would kind of expect them to think logically. So that abstract thought's not happening until 7 or 8. So it's really important for us to meet them where they're at. And these stages and these basic developmental theories really help us to demonstrate that, provide education, and move patients along. And it really helps, like in Vygotsky's theory. So I use that scaffolding all the time. So it really helps when because parents, when you talk to them about meeting them, a lot of the times when you're working with school-age children and younger, and sometimes even teenagers, especially if you have teenagers that are functioning at really lower levels. When you're talking with parents about meeting them where they're at, I have a lot of parents that have a difficult time overcoming that barrier. So a lot of my work is just getting them to overcome that barrier. I have some kids who are autistic and they're 13 years old, but they truly function social emotionally at like a 6-year-old level. And so parents expect them, because they see this maturity in them in other areas. And so they expect them to function and think like a 13-year-old, and it's just not going to happen, right? And so we talk to them about meeting them there, and we scaffold that so that the parents support them, so that the patient themselves feel like they can do it themselves. And so we're building that cognitive capacity for them to be able to get there and do that. But I think slowing down and helping parents to do that, helping patients to do that and identify that is really helpful. You have to tread more lightly when it comes to teenagers, because if you tell them that they're a teenager but they're functioning at a lower level, they get very defensive, naturally so their impulse is just to respond that way. So you just kind of have to watch your language and approaching it and treating it more that way. But to be honest, the more that we work at it and identify that, and they trust you and have that therapeutic relationship. I've had teenagers that have worked really hard to get where they need to be. And I've had some teenagers that have said, I'm just never going to be there, right? I'm just never going to get there. And we talk about ways to get there. And once they start seeing success, they move along. It's, when you talk about it, it's a nice flow, but it doesn't always happen that way. There's a lot of different barriers that you come about. But this is like practical magic, I feel like, because, when you look at some of the basics of development, you can see where it fits in. You could see where if in Maslow's hierarchy of needs, if you had some of those blocks down, if you had some of those cracks in the foundation, you could clearly see where some of this development can fit in, right? You can see where it's important for that social emotional development. It's important for that attachment, feeling loved and belonging, play and fantasy. I had one kid, he was 14 years old, and he had experienced extreme trauma, lived with grandma, and actually they started coming off for his little brother. And when he would come in, he would sit down and play with baby toys, and she would just get so livid. She would be so angry that everywhere, she's like, everywhere we go, he does this. He plays with the baby toys. He'll find the 5-year-olds and play with the baby toys. And so there was a level of play and fantasy that he needed fulfilled. And so we talked about ways to appropriately allow that to happen while still having some other expectations of him. When he was 6 years old, he couldn't play. He couldn't be in pretend. He couldn't have fantasies because when he was 6 years old, he was taking care of his 3-year-old brother when their mother would lock them in their room and leave for hours at a time. They had to worry about food and when they were going to the bathroom and when the caregiver was going to be there. They had to use their cognitive capacity to just meet their basic developmental needs, right? Their brain went to all of that neurological, all of those neurological resources just went to their basic needs. And so then they miss some of these other pieces of development that are really important to still have. So a lot of the times kids will revert back to some of these while they still display, maturity in other areas. So parents find it very hard to look at that. Once he was able to play with some toys and do that, he started growing and developing a little bit faster. And grandma was pretty surprised, but it took a lot of work. I mean, a lot of work. Like we had sessions every other week for about 6 months before grandma really accepted this. And then after that, she still had to be reminded. And a lot of my parents, with kids who are functioning at a lower level, they have to be reminded consistently. And it's a discussion all the time, and it's really hard sometimes. So when you look at providing treatment, it can be different. And so like we said, cognitive capacity, the aspect or that abstract thought doesn't come till like 7 or 8. So that cognitive capacity shifts and changes. So for children, naturally, when you're working with children 5 and under, behavior modification and play therapy, those are my go-to, right? Different strategies amongst that, and especially trauma kids love the play therapy. CBT is not going to be as effective with children unless you're doing it within the dyad. And so for children, especially 5 and under, it should be mostly dyad work. A lot of trauma therapy is more individual, but you're pulling the family in to understand the trauma. But cognitive behavioral therapy, you can teach children to memorize the strategies, the coping strategies, and they're great at doing that. But you definitely have to pull in the parents. So it's most effective when you pull in the parents and you're teaching the parents on how to identify when to utilize those strategies. So, cognitive behavioral therapy has that, it's your thoughts that impact your emotions, that impact your actions, right? And the thing with children who don't have that abstract thought yet, they don't quite understand when that thought's coming about or how to manage it when it comes about or what that thought might be. And so they can memorize strategies, but it's up to the parents to kind of identify when that happens and to help implement it. And then group therapy can be very beneficial for kids, school-age children. They love to identify with their peers, identify that what they're doing is the same with their peers, so it's very beneficial. So all of those are very beneficial. For adolescents, cognitive behavioral therapy can be beneficial. Some DBT has been very successful with adolescents. Just that reflective capacity, mentalization kind of slows down that emotional piece, allows for that decision-making piece in their brain to kind of build and strengthen, which is important. It's like exercising. They have to do that over and over again. And of course, all the research supports group therapy with adolescents to be most effective. It's really important what their peers say and think of them. So having a healthy outlet within a group therapy is beneficial. along with motivational interviewing. So system challenges in helping. And I think with children and adolescents, it can be very similar. There's some that the stable living is just a little bit different, and confidentiality can look a little different. But access, especially here in West Virginia, you know, we have trouble with access and transportation. A lot of places and clinical facilities have regulations where they no-show, you know, after so many no-shows, they can't come back, which is really trying for children because it's not really their fault with transportation. I know here at WVU Medicine, we really, our child section really works with our case managers to kind of understand that, because transportation is an issue. Access to specialists, having access to specialists and different services, that's definitely a barrier to helping. It's definitely a challenge. Stable living conditions, we have a lot of children and adolescents who move around, have multiple caregivers. So multiple caregivers in and out, that threatens that safety and security, right, of those Maslow hierarchy of needs. There's our magical piece, our practical magical, looking back at it. But routine. So routine is really important for safety and security in children, not so much in adolescents, but it helps. For adolescents, you know, one of the system challenges is homelessness. A lot of our adolescents, they couch surf at friends' houses, aunts' houses, grandparents' houses, right? So stable living environment is really important for them as well. And we have a lot more of homelessness than I think we realize with adolescents, because they float to different multiple homes. And people do take them in, and I mean, it's kind of hard not to. Confidentiality. So with children and adolescents, it can be the same and it can be a little bit different as well. Confidentiality, of course, everybody knows everybody in a small town, so that's always a system challenge. You know, one of the issues I run into with children and adolescents in focusing in kids 5 and under or school-age children, a lot of the times I'm doing dyad work. And once kids move to adolescence or needing their own individual psychiatric symptoms addressed, I have to refer them out, because there's a level that they don't feel like is going to remain confidential because we've been doing dyad work. And so a lot of the times we do shift them to another therapist. So that's a level of confidentiality that's important. Children and adolescents both want to know that you're not going to tell their secrets. And so I've had both children and adolescents try me. I actually had, it was so interesting. I had a family, a sibling sessions that I would do. So I did sibling sessions with this one family who were separating and divorcing. And, you know, we've talked before about how to address family and hierarchy, and how it's really important to join with the hierarchy and that person that's kind of in charge. And the oldest sibling was the one in charge. And so once I was able to gain his trust, it was interesting, because in one session he said to his sister, who was the youngest, he said, "You can trust her. She's not going to tell mom. I've told her a lot of things." So, you know, that confidentiality is really important to them. But I think, you know, as we look at this, it's in thinking about our first slide, you know, it really is becoming more prevalent within children. And so addressing early on, you can see, you know, the CDC puts out how, you know, behavior disorders really are higher in younger children. And if the behavior disorders are just a symptom of underlying issues and it consists, then it's going to lead to more of the depression and anxiety later on and into adolescence, amongst some. But it's really important for that early intervention to really intervene earlier. You can see that anxiety is increasing in early ages too. And a lot of the times what we're seeing is it's really the anxiety of the parents that are transferring onto the children. And so it takes, and like we said, that's a level of toxic stress within itself. And so it takes just a little bit of intervention early on to help assist that. Helping families identify and recognize how they're impacting one another is important. And that's early on. Adolescence, I think that's a little more difficult. So you're working more with the individual symptoms. But you know, like I said, working with children, I've just come back and fallen on the developmental the developmental milestones and looking at those theories, and it's been really helpful. And I'm telling you, it's like practical magic when you're able to fall back and really help parents identify that. You know, it takes a while sometimes for them to identify it, but it's like magic when they can identify where their children are, meet them where they are, help communicate effectively where they're at, and engage with them effectively. Then it's like, oh my gosh, like it's so hard to look at them this way, but it's so helpful. And so it is like practical magic. It doesn't happen overnight, but it's like poof when it happens. So I really enjoy that piece. So, I mean, everybody works with different populations, and everyone is important when you work with children. I think that anybody who works with children is definitely a hero. Any questions?
That was awesome, Amanda. Thank you so much. And I love the Mr. Rogers quote.
Yeah, good. I love quotes.
So I know we did get some questions in beforehand, but anyone out there who had any questions for Amanda regarding her didactic, please, you can chat us, you can just unmute and ask them as well. Okay, well, why don't I actually just jump right in then? If anyone thinks of any questions along the way, feel free to ask them, of course. But one of the questions we got beforehand was, wondering how generalists can learn how to engage children and adolescents on televideo sessions.
Yeah, so so that's a new exploration, right? We've been talking as a section, we meet and we kind of talk about different creative ways to engage. And I think it's really important to understand the platform you're coming from and the capacity of their their Wi-Fi as well. We live in a rural area, and the reality is that a lot of our patients have little to no service, and so that is a huge struggle. With children, it can be really difficult to engage. A lot of the times, having some of the same activities planned in advance or ahead of time, I'll prep my families with playtime. I'll prep them with what type of toys to have present. I'll prep the parents with what I'm looking at, what we're going to be working on, how they're going to interact with them. We sometimes reading a book and having that same book or reading them, together is beneficial. I've also utilized, again, depending on what platform you're on, I've also utilized social stories. So bringing up social stories videos on like YouTube. There's some great Be Like Buddy is what it's called videos on YouTube, and they're great social stories to utilize and engage. I have some patients with intellectual disability, and actually I totally thought it was going to be a bust with him, but Dad wanted to still try a virtual visit, and we did, and he engaged better in our virtual visit because it was screened for him, and so he really was stimulated and engaged, and we had that. In different platforms like Zoom, you can do different fun things like a poll. I've done polls for some of my teenagers on Zoom where they kind of can just, we had a sibling session, and they could differently kind of put in different answers, and then we could show them what the answers were. So that was fun. But I don't know, Dr. Swagger, do you have any other ideas of engaging virtually?
Yeah, so I've had the same experience actually with a lot of kids and adolescents. I found some of them actually really like the video better than the in-person appointments too. And certainly, I think teenagers and kids, I mean, being on a screen is kind of part of their world, and for some of them, it's helped connectivity. One of the things I have done, and it kind of is sort of important to think about your level of sharing, but I'm still working from my office, so I usually do some introduction time at the beginning with them about showing where I still am and talking about how my world has changed. And then I've tried to build into the videos, show me the things about your life and tell me about you. And it's actually been really cool. I've learned a lot about kids, like their pets,
Yeah.
I've learned about things that have explained things too. I've had one kid that has really struggled with video games and how much screen time, and often gets aggressive, and I've been trying to give these recommendations and they have gone nowhere. And on the video I actually saw this kid's bedroom with a shrine to all things electronic and like 100-inch television with all, and I was like, oh my gosh, this is why this is never going to work, and a reality check for me. So I've used the video, and I think it's been kind of cool. And sometimes I've had kids like want to see a toy that they knew was in my office, and so I've tried to talk about what we're doing, because sometimes kids are kind of worried about you, and you forget to realize that that's sort of part of their discussion. So I've used telemedicine as an opportunity, and a lot of kids have told me at the end how much better they like it. Many of them have said they preferred to keep the videos going so they didn't have to drive, and it would save time for their commute to get services. So I have struggled significantly with nonverbal kids and kids with low IQs. Sometimes they just don't get the concept, but they do much better over video. One of our neurodevelopmentalists also gave me some really good tips for assessing little kids, because I see 3- and 4-year-olds, and I thought that was going to be impossible. And I've done a lot of actually video visits for new patients that way. And one of her best suggestions was to take your camera and have the camera positioned in the child's favorite place and just watch the child play while you're talking to the parent. So the parent can either talk through the phone, you don't have to see the parent, and you can really get a sense of the child's world, sometimes better than in our office. And that's been really helpful. I can actually see that child running all over the place, or you might pick up on some social issues. So in some ways it's added a really nice diagnostic and personal touch. And so I found all those things really helpful.
That's awesome. Those are all such creative ways to engage kids and adolescents and teens. I know personally in some of the Zoom calls I've been on, just with meetings and everything, you can change your background, and that, I don't know if that's distracting, but it might also engage the child or something. It might be something fun for them to try out as well through any time.
We've also modified like icebreakers. So sometimes using some icebreakers. I know for my one group I used icebreakers, and we do a would you rather. And so, you know, would you rather, like, and you can, if it's the first one, you raise the roof, and it's the second one, you do like a butterfly, and kids love that. So they, I mean, especially the school age and teenagers, like the school age loves the would you rather. So I always do that with them.
That's awesome. And Amanda, you got a lot of thank yous for your excellent presentation. So I just wanted to throw that out there. So the next question we got was, they were interested in some best practices related to managing or handling teen patients whose parents are in the process of a divorce or may already be divorced and going through custody battles. Perhaps some tips on ways to support the teen in their developing autonomy and decision-making skills, while also not getting caught in the middle of the parents' issues.
Yeah, I can hand that out, but I've developed a handout where I've kind of gone over with parents of how they can manage during a divorce or separation, and not really including. I think that's really complex, and I think that those cases are really difficult, and they usually end up pretty messy, but it's really important to support that teenager along the way. A lot of the times for, you know, I think of one of my messiest cases right now, it ended up being, you know, that the teenager asked that they not have any way to schedule for them or any involvement in their treatment. And sometimes that separation is just really important for them to build that autonomy. It's their time, it's their sessions, and it's their therapy. And so really understanding that, and that's your primary patient. I mean, best practices is that that's your individual patient. And so unless they want to do family work, you don't move towards that unless it's something that they're really moving towards. I don't know if Lauren, you have anything else with that.
Yeah, thank you, Amanda. Dr. Swaggart?
Sorry, I keep trying to mute myself. I certainly echo everything Amanda said. I have mine might be a little bit more focused on documentation because I'm usually managing medications, and sometimes it's challenging, and you have to also know the laws in your state. In West Virginia, only one parent has to technically consent for treatment. But both are entitled to be aware of the patient's diagnosis and treatment plan. So even if a patient may not have, and parents are always get very stuck in this, I have custody, they don't. That's not really the law. The law is unless their parents' rights have been terminated or their legal or medical decision making is terminated, typically biological or adoptive parents maintain medical rights to that information. And so I think being aware of that and being honest, I certainly if one patient wants a medicine and one doesn't, you sometimes have to make decisions not to prescribe as a result of that, or being very clear with parents what that will do. Certainly with things like ADHD, it's pretty easy because you can take ADHD medicine in one patient's home, or you can take and not in the other home. It's not ideal, but it's not medically unsafe. And where you work on negotiating points, like we take it in school and the school gives it. And so in those kind of conflicts, those things can be helpful. I also would be cautious about your documentation. Make sure that you speak in general terms that get the theme and stay away from things the patient might say or not say for if those records got in the wrong hands. It's also important to be cautious that you document things like if one parent says about the other parent, you don't write that's fact, because I've had parents allege medications or diagnoses that didn't really attribute themselves to another parent when they're in a hot divorce situation. I actually am going through this now, but my records were sort of requested from a patient, and in most legal statutes, if you believe that your medical records contain information that could endanger that patient, you actually have the right to refuse that. You just need to document that. I actually had I have a family with a very high conflict divorce going on, and I refused records to one of the parents, and he actually turned me into the medical board, and that complaint stood up as well. So again, these don't usually happen. The other thing I do is for the medicines, I try to always, if both parents have always been involved, I try to call that parent at that appointment. So if one brings them, I call the other one to discuss the treatment plan right there, everybody on speakerphone, so there's not splitting that occurs. And if they can't handle that, we take turns. This parent brings this patient to this appointment, then other one brings them the next time. It's just sort of practical ways, especially it's very high conflict, kind of also manage the other things that might be going on so that you stay there for the patient. But it's hard sometimes about that, and ultimately you have to respect that you are on the side of the child and whatever it takes to make sure they're getting the right treatment. So.
Yeah, I would agree with. I think the biggest piece, is like you were saying, Lauren. Like one thing that I found is just being very honest with the parents up front. I've had parents that bring their children to therapy just so that they could take it to the courts, and it's not about that. Just so that they understand that this is about your patient. And if that's what they're looking for, then they need to get forensic interviews for that.
Absolutely. Thank you both so much. We have about 15 minutes left of the session. Were there any other questions for Amanda? Questions, comments, concerns, how your personal experiences have been going? Feel free to use the chat as well if audio is an issue.
So I'm curious how you all are doing. I haven't gotten to see our fellow ECHO group for a while, but I have to tell you, I had never done telemedicine before. I think I had done every other service on the planet, but I had been afraid of telemedicine for some reason. And I've learned 4 platforms. I have totally drinking the Kool-Aid because it has been a phenomenal experience to still be able to deliver behavioral health care. And it's so adaptable to what we do that I'm totally on the telemedicine bandwagon of telemedicine for all. And I think especially in our state, to get into the nooks and crannies of our rural communities with transportation issues, I have become a force of this, and I hope it does not go away. I know that broadband and internet access have been a challenge in our communities. We have people driving to McDonald's and using their cell phones on the hotspots outside of McDonald's and Walmarts, and it's going surprisingly well. So I'm curious what other people's experiences have been. I know that there are different challenges when it's not related to behavioral health or psychiatry, but I've totally been drinking that telemedicine Kool-Aid, and so I wonder, I'm kind of curious how the other group has managed that.
Oh, I think you might be muted, Vanessa. Here, okay, there we go.
Okay, I'm Vanessa Perez-Weiss from Bethlehem Neighborhood Health Centers of the Lehigh Valley. This has really been an excellent presentation. Thank you so much. Here in Bethlehem, we serve a urban community that has a lot of needs in terms of lower resources and income, and having all of the technology for the video visits isn't really something I'm finding doing the telehealth. So we have to convert to the telephone, and I was told that that reimbursement really isn't equal to a video encounter. But we are offering telephone visits and hoping to offer more video visits for our people, especially since it looks like with the COVID-19 that this like restricting our social interactions and so forth is going to be something that we'll be facing for some time.
Absolutely. I know I've heard a lot of feedback from everyone saying that ever since COVID and telehealth has been implemented, everyone's been as productive as before, if not more. So it's definitely an interesting time. So we got a chat in from Amy that she has not used telemedicine yet, but is encouraged to hear that it's going so well. So yeah, I think we're all really encouraged and hopeful that it's going really well for everyone. Were there any other experiences or comments about how everyone else's telehealth has been going?
Well, I mean, I do integrated behavioral health out here in Hamlin, and like we're in Lincoln County, and we're having trouble keeping telephones down in the rain, much less broadband internet. So that's been a struggle, and it's been interesting. Like people have been canceling sessions to get their essentials. Like I can't have my intake today. I have to go to Walmart.
Yeah, definitely. Were there any other questions or comments?
This is Donna Burton. I'm a nurse practitioner in Sissonville, Kanawha County. So as a nurse practitioner, the telemedicine has been both good and bad because I see patients who really like it, and it's going to be more difficult to get them to come in and actually have hands-on and get labs because they like being able to stay home and take advantage of it. That's the ones that actually have access, and we are limited in our access, and we're doing a lot of phone visits as well as seeing patients outside the office in the parking lot. So it's a new world.
Thank you for sharing that. Definitely a new world we're all adjusting to. We have a little under 10 minutes. Everyone is welcome to chime in. How are you guys doing? Surviving through COVID. I don't want to keep you all longer than we have to, but feel free to email me also with any questions you may think of after the fact, and we'll be sure to have them answered and sent back to you. I do have one quick announcement before we end, that our next session will be on May 20th, and Dr. Goody Coons is providing our didactic on ADHD diagnosis. So keep an eye out for reminders on that. I really want to thank Amanda for the excellent didactic. It was so great. And I'm so happy we had so much great feedback and everything. Thank you, Dr. Swagger, as well, for answering some things and chiming in as well. We appreciate all of you guys. So thank you all for
could I ask a question really quick for Dr. Amanda before we go?
Sure, absolutely.
I was wondering with the Eric Erickson's developmental. Are you able to hear me?
I am.
Okay, great. If a child or even I guess an adult, depending, is somewhere on the hierarchy, is there a chance that they're just there in one sphere of their coping, or is it all of their spheres? And do they need to then progress through all the stages to get up to the level that you would expect them to be at age-wise?
I think that's a great question, and you know, a lot of the literature that I've read, you know, it's hard to determine that, but it's basically usually in like one sphere, right? And many of the times, you know, if you have one child that's struggling in one sphere of that development, you know, and needs to progress, sometimes they go from, once you meet that need, they go all the way back up where they need to be. And so I think it just depends on each unique situation and what they've endured. So and usually it is just that one sphere. Now I've had kids who have had significant trauma, and really some medical issues as well. And so, and I've seen them in all domains. So, I mean, it just depends, but most of the time it's usually like one area that they struggle with. Like I have some trauma kids that, you know, there's pieces of their development that they've missed, and they've continued to grow and develop and move along social emotionally, but they still have struggles in that one area. So it's about meeting that need to move forward. And sometimes, I mean, some of the one trauma kid that I work with now, she's going through each developmental stage with this just little area of like incompetency that she's having.
Yes, for example, like trust versus mistrust, like the first one, if they haven't achieved that and they have so many other stages.
Right. So, and they've achieved other domains in the other stages. And so it's just about kind of meeting that so that they meet optimal development, right?
Okay, great. Thank you. That was so helpful. That was really, really excellent.
Oh, I'm glad.
That was really excellent. Thank you so much again. We do have 5 minutes, so if there are any other questions, more than welcome to ask them here. All right, guys. Thank you so much for joining. We'll see you guys next time. Stay safe.
Bye.
Bye.